My name is Cristina Has. I'm a senior dermatologist at the Department of Dermatology of the University of Freiburg in Germany, and I'm going to present the clinical practice guidelines for epidermolysis bullosa laboratory diagnosis. This guideline was published in 2020 in the British Journal of Dermatology. It resulted from the collaborative work between experts from all over the world, people living with EB, and Deborah. The work extended over 3 years almost in different working sessions. In this guideline, we provide the steps in making an accurate diagnosis in case of clinical suspicion of EB. And it's therefore recommended that laboratories consider the testing criteria formulated and agreed by these guidelines. Of course, in real life and in different countries, the situations might be different. And every family and every person with EB might have another situation. In these cases, EB clinicians and diagnostic scientists may need to make reasonable adjustments of these guidelines, but not deviate too much from our recommendations. Laboratory diagnosis is important for someone with EB or their immediate family because of several reasons. For accurate genetic counseling, for prediction of disease severity, informed decision-making, appropriate global patient care, prenatal diagnosis, benefit of specialized medical care and wound dressings, personalized medicine, participation in clinical trials, and for the ongoing treatment. The most common situation is that of a newborn with skin blisters or with congenital absence of the skin, in which we have the question which EB type or subtype is here the diagnosis, what is the prognosis, how should we counsel the parents, and how to offer prenatal diagnosis for subsequent pregnancies. The traditional diagnosis relies on skin biopsy. In EB, the upper layers of the skin, the epidermis and the dermis, do not adhere correctly, so that after mechanical stress, cleavage occurs, which clinically represents the blister. And by analyzing the skin biopsy with a technique called immunofluorescence mapping, we can determine the level of blister formation and whether one protein associated with EB is reduced in its expression or completely missing. With this, we can classify the EB type or subtype, in particular in cases with severe fragility, when a protein is completely missing. If the skin fragility is mild, you might not be able to make a diagnosis with this technique because there will be no cleavage and no change in protein expression. The second method for EB diagnosis is genetic testing. And with this genetic testing, we can precisely determine the mutation that causes the disease in each case. And we have to know that there are pathogenic variants in 16 genes now known in EB. So I will explain later how we proceed nowadays to be more precise in this genetic diagnosis. So in the process of generating the guidelines, we proposed diagnostic flowchart that is represented here, and I will go through these steps. When a person is suspected of having EB, as I showed you, we may take a skin sample for diagnosis and a blood sample for genetic testing. But before doing this, we have to carefully observe the clinical features to find out whether there is a kind of family history of a similar disorder. And we have to exclude differential diagnosis, like acquired or other genetic disorders that manifest with skin blistering. And we can take the time for this diagnosis, in particular in children or in adults, but in newborn, as I showed you before, the diagnosis should be quite rapid. And for this reason, the skin sample analysis, in particular by immunofluorescence mapping, can provide a diagnosis within 1 or 2 days, depending on the laboratory, and give us a broad determination of the type or the subtype. Genetic testing takes usually a little bit longer because the methods are more complex and must be validated, and the genetic report must be written that is scientifically based. In case of genetic testing, we have two outcomes that are possible. Either we find a clear disease-causing variant that explains the disorder and the phenotype. And with this, we can move forward to write a report, explain the parents or the family what is the relevance of the result, and such a case will be completely solved. On the other hand, in some situations, we find the so-called variants of uncertain significance, or we find no disease-causing variant in any EB gene. And in such situation, we have to perform more functional studies and more sophisticated methods that will be actually on the research basis. And now just a short overview of the immunofluorescence mapping that I have briefly described before, how to take a skin biopsy for EB diagnosis. We usually need a biopsy from a fresh blister that is not longer than 12 hours, built for 12 hours. And we also need a part of non-blistered skin where we can better appreciate the different markers of the skin. So on a slide, two sections of the skin sections of the patients will be mounted, and one of the control skin, and antibodies to different structural proteins of the dermal epidermal junction that are associated with EB will be used for this immunostaining. The positive signal is always the green one that we see here. It can be also stained in red, but it is a definite staining pattern, whereas some samples here do not stain at all, meaning that the protein is not expressed. And by appreciating the position of the different proteins in respect to the cleavage level, we can make the diagnosis of EB. What about genetic testing? Genetic testing is done by sequencing of the DNA sample, and there are several techniques. The classical technique is the so-called Sanger sequencing that was established some decades ago and served us for a long time. This is a quite tedious procedure in which gene by gene must be analyzed. We use it nowadays only in the case of recurrent population mutations, or when we are absolutely sure which is the candidate gene, if this candidate gene is small enough to be analyzed. We also use it to validate familial variants that we already know. But for all other cases, nowadays we use the so-called next generation sequencing, which is a more sophisticated method by which many genes can be analyzed at once. And we use the so-called EB gene panel, meaning that we analyze all known EB genes at once. Then we filter the results and find which can be the small error that causes the disease. There are also other laboratories in other countries that use even more extended approach, the so-called whole exome sequencing. With this method, actually, all exons in known genes are analyzed, meaning that we have at once a lot of data about the genotype of the person. Usually, the laboratory personnel is only looking then at EB genes, extracting the information which is necessary for the patients. But sometimes when the phenotype is more complex, also other genes may be evaluated. A next method is the RNA-seq, by which the RNA is analyzed, not the genomic DNA, and this must be extracted from a skin sample. This is a more research method by which we already see what happens in the skin as a consequence of the mutation. And finally, the broadest approach is the whole genome sequencing, by which not only the coding sequencing of a gene are analyzed, but the entire genome. I think this is not used in the diagnosis, it's rather a research method. So these are the currently used methods for genetic testing. The results, as I mentioned before, can be different. One may find genetic variants that can be classified in 5 classes. Class 1 and 2 are non-disease causing, also non-pathogenic, and can be called also benign. They correspond actually to the previously known called polymorphism. And then we have class 5, which are the clear disease-causing variants that we previously called mutations. Class 4 are also probably pathogenic, so variants that have a high relevance for the disease, probably. And the gray class is class 3, the so-called variants of uncertain significance. This means there are variants that we cannot assess with the existing information, whether they are disease-causing or not. And to clarify whether such a variant of uncertain significance is disease-causing or not requires more sophisticated methods. Anyway, if we don't find a clear disease cause, we have to go to the research and use methods as RNA sequencing, immunohistochemistry, immunoblotting, cell culture, in order to find the cause of EB. And this is not diagnostics anymore. Now, coming to the laboratory report, let's see how this can look like. In case of immunofluorescence mapping analysis, we can have a clear positive result when a protein associated with TB is missing, and we can say the patient has a clear, severe junctional B diagnosis, for example. But we also can have a negative result when nothing is wrong in the skin. This we will call a negative result. And in between, there might be unclear results where more proteins are affected or there is an unclear level of skin cleavage. In case of genetic report, we can also have a positive result, a clear disease-causing variant with a clear diagnosis of dominant dystrophic EB, for example, or we can have a negative result when we find nothing in any EB gene or an unclear result because of a variant of uncertain significance. Now, the next step in the procedure is the genetic counseling, because each genetic report must be explained to the patient and the family. And this is not something trivial, and not every family doctor can do this. And also the patient by himself or herself cannot understand the complexity of such a report. So either a genetic counselor or geneticist or a physician who has experience with EB must explain this result to the patient or family. And this is done in the frame of this genetic counseling. The genetic counselor should explain to the family what EB is, the inheritance pattern, the specific results of the laboratory tests, the prediction of disease severity, the options for family planning, and the options to perform a prenatal diagnosis in future pregnancies. Now, concerning inheritance, EB can be inherited in 3 different ways: autosomal dominant, recessive, or there might be a de novo genetics. And these inheritance patterns are explained here. Regarding the autosomal dominant inheritance, the disease is present in one of the parents on one so-called allele. And this can be transmitted to the next generation with a risk, a probability of 50%. And this risk is for each pregnancy. It's not a global risk for the entire, for all the children that they will be born. In case of the autosomal recessive inheritance, parents are healthy, they are carrier of one mutated allele, which is not expressed in the phenotype. So each of the parent can transmit the affected allele to the next generation, and the probability of a child to have 2 mutated alleles is 25%. Again, for each pregnancy. The probability for the child to be carrier is 50%. The last situation is when both parents are healthy and they are also not carrier of a mutation or a pathogenic variant. In such situations, the disease-causing variant appears de novo in the germline and is transmitted to one of the offsprings. In these cases, affected people with TB are usually single affected in the family, and the transmission, which is usually autosomal dominant, starts from this generation on. So it's very important to determine the inheritance patterns in EB, to inform the families on the risk of transmission to the next generation, the risk of recurrence in future pregnancies of the couple, and then based on this, prenatal testing can be planned. And this is usually done when the mutation is known in the family. And with this, I come to the last part of this presentation to show how this guideline works in practice. And this is a baby newborn with congenital absence of skin and with some lesions around the nails. Just on clinical features, we cannot make the diagnosis. But if we take a skin biopsy, we can appreciate that laminin 332 is absent, and this makes immediately the diagnosis of severe junctional epidermolysis bullosa due to laminin deficiency. And if we make the genetic testing, we determine the underlying genetic variant, which is a homozygous LAMB3 recurrent variant in this case. And with this, the diagnosis is clear. The prognosis is unfortunately not good for this child, but we can counsel the parents and provide a prenatal diagnosis. Another case, quite similar, congenital absence of skin and some lesions around the nails. Let's see if we have the same story. Not at all. As you see here in the skin, there is no blister, but we also don't find any protein to be missing. That's why we have to proceed immediately to genetic testing. And with genetic testing, with this Epidermolysis bullosa gene panel, we identify quite fast a keratin 5 mutation, which makes the diagnosis of severe epidermolysis bullosa simplex that has actually on the long term a good prognosis. And since both parents are not affected and don't carry this mutation, it is a de novo keratin 5 mutation. For the family, it's also important because the risk of recurrence is very low, actually almost zero for the future pregnancies of the parents. But of course, this newborn as an adult will transmit the mutation to the next generation. The third case looks again quite similar. There is congenital absence of the skin, and there are some other complications like growth retardation, polyhydramnion, and fluid-filled stomach. And here the situation was much more complicated. We found in the skin that the integrin beta-4 is absent, and alpha-6 as well, meaning that this was a junctionally B due to integrin alpha-6 beta-4 deficiency. genetic testing identified an integrin alpha-6 mutation, and here the situation was more complicated because there was a uniparental disomy, which means that there is a more complex mechanism of transmission from only one parent to the offspring. But such situations are rather exceptions. The prognosis is very severe for this child, which died very early, and for the parents, actually, the risk of transmission is exceptional, actually is almost zero, because such a disomy is very rare. Now, another child with blisters, itchy erythema, nail dystrophy, failure to thrive, and recurrent infections. So this pattern does not fit in a EB phenotype precisely. By skin biopsy, we found that plectin is absent, but because of the complex phenotype, whole exome sequencing was performed, and what was found was not only a plectin homozygous mutation, but also a homozygous mutation in another gene, CARMIL2, which caused severe combined immunodeficiency. So in such situations where the phenotype cannot be only explained by an EB type, whole exome sequencing is helpful to disclose a second disease, in particular on a consanguineous background. Another situation of a woman with pretibial blistering and scarring who asked for genetic counseling. So by immunofluorescence staining, there was a dermal cleavage suggesting a dystrophic EB, but there was not clear whether the transmission is dominant or recessive. Genetic testing was performed showing two heterozygous pathogenic variants in the COL7A1 gene. So it is a recessive dystrophic EB, and for the genetic counseling, the partner was also tested for common COL7A1 mutations, and so they could be given a genetic counseling that the risk of transmission to the next generation is actually zero, because the offspring will be carriers but not affected. Another woman who had no diagnosis of EB actually until the age of 54 years. She had some scarring on the knees, nail loss, and some scarring in the oral cavity. Was considered to have acquired inflammatory skin disease until we performed the molecular diagnosis for EB. As you see here, by immunofluorescence staining, type 7 collagen was strongly reduced in her skin, and by genetic testing we identified two heterozygous pathogenic variants. So this lady has a recessive dystrophic EB, intermediate form, and she had finally a clear diagnosis. The last case that I bring was also tested very late in life. A 70-year-old man with fragile skin, scarring, and nail loss. His son asked for genetic counseling. So based on the skin biopsy, we couldn't draw any clear conclusion because there was no protein missing and there was no blister in the sample. So we perform genetic testing by using the EB gene panel and identified a homozygous recurrent collagen 17 mutation that causes the so-called junctionally B late onset. This is inherited in an autosomal recessive manner, so his son is an obligate carrier and he can transmit this mutated allele to the next generation. Whether there will be an affected child depends on the carrier status of the mother. So with this, I hope that I gave you an insight into the laboratory diagnosis of EB and into the way in most laboratories around the world this diagnosis is performed. As I mentioned, EB is complex and sometimes the diagnosis must be personalized and sometimes it must be extended to the research area to clarify all cases. With this, I want to thank all my colleagues who contributed to these guidelines, the reviewers, the people living with EB who provided their input, Katja, who guided us, and also Deborah for funding. Thank you.